Good afternoon. My name is Jamie McLennan. I'm the ABIM Foundation's Communications Manager. Thank you for joining us for our Trust Conversation webinar series, which is a core element of the Foundation's Building Trust initiative. We're joined today by Chaplain Elizabeth Tracey, the Director of Johns Hopkins Health NewsFeed and founder of the This Is My Story initiative, or what we'll call TIMS, which gives care teams a humanizing window into their patients' lives and helps to build trust between patients, their loved ones, and clinicians. We're also joined today by Dr. Richard Barron, President and CEO of the American Board of Internal Medicine and the ABIM Foundation. Again, thank you for joining us for this conversation, and I'll now turn it over to Dr. Barron and Elizabeth.
Jamie, thank you so much for putting us together and giving me an opportunity to talk to Elizabeth Tracey in front of a large audience. And if I had my way, Elizabeth Tracey would be talking to every clinician in the United States. I think that she's got a track record of doing extraordinarily creative, relevant work that locates clinicians and patients in the universe in which they belong, of mutual caring and mutual knowing each other and mutual trust building. And when I learned about the work that Elizabeth had done, I just couldn't believe I hadn't heard about it before, and I couldn't wait to share it with a larger audience. So thanks all of you for joining. And Elizabeth, I guess where I would start, for those of you who didn't get a look at her bio, she's someone who's in the communications department with the title of chaplain. And the obvious question was, what's a chaplain doing in the communications department? Elizabeth, could you start there with the group?
I'd be delighted. And Richard, first, let me start by saying thank you so much for this opportunity to talk about something I'm really very passionate about. And that's, of course, TIMS, This Is My Story, the initiative that we developed initially at the beginning of COVID. So you asked me to address this question of how in the world does a chaplain become part of the communications team? And I started out as part of the communications team. So I'm director of electronic news media, and I do this daily radio spot that's called the Johns Hopkins Health NewsFeed that's broadcast on CBS Radio, Voice of America, and all sorts of outlets, both nationally and internationally. And in that role, what I do is I look at the peer-reviewed literature on a daily basis, and then I reach out to the appropriate Johns Hopkins medicine faculty member and conduct an interview about, hey, what do we need to know about this particular study and how does it fit into everything else we know already? So that role then led me to become aware about 14 years ago of a study that was in the New England Journal of Medicine that I bet many of our participants are familiar with, that was looking at the benefits of palliative care and extending the lifespan in people with stage 4 lung cancer. And that study established that those who receive palliative care versus those who got standard care live longer. So when I went to interview Tom Smith, who's head of palliative care at Johns Hopkins, he said, well, it's really a team approach, and part of the team is a chaplain. So when I asked him to explain more about the role of the chaplain, he said, why don't you go over and talk with the head of spiritual care and chaplaincy? So I did that. And I asked if I could have permission to shadow a chaplain, and Paula Teague said, sure, you can shadow a chaplain, but why don't you just apply to the program? And I said, well, why not? I don't have anything else to do. And so I started the formal clinical pastoral education program at Hopkins. I did the 2 years, got board certified, and then started working in the medical intensive care unit, the MICU.
Wow. That's an extraordinary story of curiosity and putting yourself forward, and also teamwork at Hopkins. What a lovely world in which people are sending you there. So when you put those two skills together, being a chaplain and the communications skills you had, where did that take you? There you were still in communications, but now you have this chaplain background. It sounds like it had an impact and shaped a couple of next steps for you.
It did indeed. And I would say that the chaplain role for me, of course, has been extremely powerful because everything that I report on now, I actually see it. And so it ends up being reinforcing and kind of a positive feedback loop with regard to kind of a developing a composite picture. So very early on in my chaplain training, or actually my last unit of CPE, of clinical pastoral education, I got paged to the surgical intensive care unit at Hopkins, and there was a nurse and the physician, or the patient, who was an older gentleman. And the nurse said to me, look, the family's left and I'd like you to pray for him. And when you're finished, we're going to page respiratory and they're going to extubate. And I've been at Hopkins for almost 22 years now, and I was in the chaplain role, have been for quite a while. And this was my first exposure to this. So I asked her to give me some more information, and she said, well, yeah, the family left. They don't want to be here. So once you pray for him, we're going to extubate. And I said, well, can you help me to understand this just a little bit further? Who is going to be with this patient when he dies? And she burst into tears and she said, I am. And that's why I'm leaving this unit, because I can't do this anymore. I said, do what? She said, be there with patients when they die. And I said, how often does this happen where you're called upon to provide presence for patients as they die and the family or the loved ones have left? And she said on that unit, 60% of her patients would die alone were it not for nursing. And so I went out to validate that whole number with all the clinicians that I know. And I've been on a lot of high acuity, high mortality units, specifically the burn unit, the regional burn unit, high mortality, high acuity, the MICU, of course. I had no idea it was that high. So I went back to spiritual care and chaplaincy, and I said, look, I think there's a need here. And so I started at Johns Hopkins Hospital a No One Dies Alone initiative, so NODA. And that was originally incepted by a nurse about 15 years ago. So we brought it to Johns Hopkins Hospital, and we've since been doing that. So that was really that synthesis, that role of witnessing the clear distress on the part of a nurse and saying, I think there's probably something we can do about this. So fast forward to COVID, I'm on the MICU, and Brian Garibaldi, who's the intensive care medicine guy who treated President Trump when he had COVID, one of that team, is also on that unit. And Brian had a study where he was looking at point of care ultrasound for assessing pulmonary and cardiac abnormalities secondary to COVID. And I was interviewing him about that study. And then I do this all the time. I flip roles on the faculty, and I said, Brian, so tell me, how's it going with these patients? And at the time, the whole unit was bio. So it was nothing but COVID patients. They were all intubated, sedated, and prone. And he said to me, Elizabeth, it's really terrible. I don't know anything about these people. I could be dealing with body 1, body 2, body 3, doing nothing but adjust vent settings and pressors and so forth. And it came to me just instantly in response to Brian. And I said, you know, Brian, I think I can help with this. How about if I reach out to the loved one, to the person identified in Epic as the point of contact? And as you're aware, there were no visitors in the hospital at all. And ask them, who is this person? Tell me about this person. Do they like Chinese food? Do they wear their Nikes without socks? Do you guys have a dog? Right? And so Brian and I got all the appropriate permissions and all that, and I started to do that. And so I developed this program, TIMS. This is my story. And because I'm accustomed to producing things that are very short, I could conduct this interview with the loved one and render it to a file that was 2 minutes or less. We put that into the chart and then gave it to the entire medical team. So on the MICU, they all round in like knots, if you will, with computers that are on their little trolleys, and they stand outside the room, and they would stand in these groups and play the file. And then they would all know something about, who is this person? And let's hear in their voice of their loved one why this person is so important. So that's how that happened.
Wow, what an amazing story. And what a way patients have been struggling to get their voices heard in hospitals and medical teams for 100 years. And you know, the famous Francis Peabody essay, the secret of caring, the care of the patient is caring for the patient, and medical teams have been reaching for ways to try to turn, and he talks about this, Peabody does, somehow the patient that's the mitral stenosis in bed 3, how do you make that person a person? And so you came up with a way not just to do it, but to integrate it into the electronic health record, to present it on equal footing with all the other data they were looking at in the electronic health record, and access it at the time that they're accessing all the other data in the electronic health record to take care of the patient. That's extraordinary. And we'll come back a little later to your thoughts about scaling, replication, what your experience has been in that space. But maybe if you could tell us some stories about impact on families, impact on caretakers of this, what you've been able to observe about that and what you hear about that.
Almost to a person, of all the people who told stories about their loved ones, we're just really delighted to be able to participate in that. And at that point, as you know, no one was allowed to come to the hospital. So this particular tool enabled them to feel that they could have an impact on their loved one's care in the hospital. And it really had a huge impact. And so some of the resources that we're going to share, I believe at the end of this talk, demonstrate some of these stories, but I'll just bore you with some of them now. So we had a patient who just got really, really cold in the hospital. And what she really wanted was for the team to put her blankets up over her nose and around her ears, but she couldn't talk. And so her daughter actually told me that in the midst of recording the TIMS file, and we posted that. And the team after that went in there and put the blankets up around her nose and around her ears. And when she was extubated, she was so grateful and so excited that she was able to actually have something done for her that was something she really wanted, but was unable to communicate. So everyone was happy with that outcome. And another story I'm fond of telling was an Orthodox Jewish patient we had who was with us for a really, really long time. And his son recorded in his TIMS file a message for his dad. And he gave his father a blessing. And he also recited his father's favorite psalm in Hebrew. And so that was in the chart, and the patient knew that that was in the chart, and he was asking the nurses to play it for him up to 10 times a day. I mean, and the nurses, after 2 months of that, were saying to me, thanks a lot, Elizabeth. You really made it even crazier for me than normal. But it was very meaningful to him in his hospitalization. So the stories, of course, I could go on and on about the impact that we've been able to see in this. And of course, we have studied this because we're at Hopkins, so we have formal studies that are looking at how it's really helped clinicians. So clinicians tell me, critical care medicine docs, and certainly nursing doctors in particular, that the file enables them to have a level of intimacy and understanding with the family the first time they meet them. And as I'm sure you're aware, they rotate every 2 weeks. And so if you have somebody with a lengthy hospitalization, what they don't want to have to do is keep on repeating the story. And this makes it so that they don't have to do that.
Right.
Because it's available.
Yeah, it's so important to find pathways to make patients people for the care teams. I remember in the years that I would round in a nursing home, often at the bedside, and often for patients who were demented or not able reliably to communicate, you'd see this stunning photograph of somebody in a World War I military uniform, or somebody in a family grouping, from the 20s or 30s, and it always kind of struck me as a clinician. Oh wait, there's all this life about this patient I don't know. There are all these things that are out of reach for me, and yet. None of us nobody goes into medicine to be in the coma ward of taking care of people in suspended animation, as you say, and ventilators prone, and sedated. And so you're finding a way to break through that. It is just extraordinary to me, and deeply moving, and reflects a kind of creativity and vision that I really applaud you for. The story of the son getting the psalm to his dad, that almost sounds like a patient hack of the system. Like you designed the system for the team to hear the patient's voice, and patients hacked it to get their own voice into the bedside. Were there other kinds of uses that surprised you of how people wound up using this technology different than you expected?
I'm not sure if I would say there was anything in particular that was different than I expected. I would also note that, especially in the MICU, these files are extremely important when there are transitions of care, and where it's clear that the patient, we all can listen during family meetings about the patient's passions. And I can tell you about a patient we had on the unit whose big passion was riding his Harley. And his family really put forward the notion that if he couldn't ride his Harley, he just was never going to be happy. And it became clear as his condition progressed and he was with us for a while that he was never going to ride a Harley again. And so when we were able to bring that recording to the family meeting and play it and hear, this is his history, these are the things he's passionate about, it really helped everybody get to a place where that decision was way clearer than it might have been otherwise. So I have seen it used a lot in those circumstances. We do offer these recordings to family members and loved ones and to patients themselves when they make their own recording, which is of course where we are now. And they've been used in lots of ways, like at memorial services and so forth during COVID, for sure, in those circumstances.
Oh. So I was just going to ask that too, that two of the things you just described related to patients who didn't survive their hospitalization. And I guess these things could become really powerful artifacts and centering. To imagine them being used at memorial services is very moving. To imagine them helping a family, in effect, process their own feelings about continued care. So when you tell the story about the Harley, clearly in palliative care, one of the big issues that people talk about is goal-directed care, and how do you understand what the patients actually want out of their care. And sometimes the decision to withdraw care comes perhaps most comfortably in the context of recognizing that what that patient really wants is something you're not going to be able to give. And it's very hard for patients to confront that. It's very hard for families to confront that when you think about withdrawing care. And the story you told is so moving. It helped the family come to peace with withdrawing care, recognizing that this person was all about riding his Harley, and if none of this was going to get him back on his Harley, then maybe they needed to think differently about what to do. Did that seem to, because obviously these things unfold in time, that the person winds up in the ICU and you're doing this recording, and then it's 2 weeks later and things aren't going so well and they're still there. Was that a common situation for the file itself to become a reference point for families trying to figure out what to do?
Very common on the MICU for sure.
Yeah.
So not so much on, because obviously that's a place where those kinds of trajectories are really common. So, but on other units, even where the patient's condition continued to deteriorate and it just looked like maybe it's time for us to think about things a little bit differently, they've also been utilized for sure. And I've been there for that.
So you mentioned this in passing before, that that the inspiration for the program was COVID times, ICU, intubated patients on ventilators prone that the team doesn't know anything about. But you mentioned that you've now expanded this to other patients in the hospital. Talk about that. Talk about how that's being used.
So as a result of the experience on the MICU, it became really clear that that model of recording a TIMS file was not going to be very scalable. And so we reviewed all of these recordings that we had made, and we were able to reduce the number of questions that we asked to just 4 questions. And so those 4 questions are, how do you, and we ask patients themselves, how do you want to be addressed? What brings you joy? What does the medical team need to know about you to treat you best? And what brings you peace? That's it. Just 4 questions. And so I'll tell you a story about that. And we started that, this distillation, and then I was working with a patient with a family on the MICU. And it was the patient's husband who answered that question. And he was talking about his wife. And when I said, what brings your wife joy? He said, well, I do, which I love that. I still love that recording. Every time I hear it, it makes me laugh. I wondered if she would have said that also, if that would have been the first thing off her lips. So then we started doing it with patients themselves, as I said, and then went to just regular old medicine units. And so talking with patients and asking those 4 questions, I really thought, and this is a study that we're just completing now, we're doing the qualitative aspect on it. But I've done about 200 of these recordings with patients. And I'm going to ask you, do you think it would be sort of formulaic, those 4 questions?
Oh, goodness. No, I think those 4 questions get at the very essence of who somebody is. And we're very different people with very different things that we want, and things that give us peace and things that give us joy. So no, I think that's just a brilliant way to expose diversity and appreciate that people really do want different things. I assume that is what you found, right?
So you're clearly a much better clinician than me and have much more abundant clinical experience, because I was worried that it was going to get very formulaic. And the fact is, it's not formulaic at all. The way that people answer those 4 questions, which seems so simple, is just all over the map. I had a person say to me, I asked him, well, what brings you joy? He says, my cell phone. I mean, I never would have answered a cell phone. And similarly, the questions about peace, and they're just all over. And clearly, this is based also on the experience in the MICU. So the question about how do you want to be addressed, it's so important. And I give this story about a patient whose sister recorded his file. And she said to me, you know, the medical team, every time they talk about my brother, they call my brother Michael, but that's not his name. His name is Chubby. They need to call him Chubby. Well, you know yourself, when somebody is critically ill, and especially in an ICU, delirium happens a lot. And when somebody addresses you in the name in which you are accustomed to being addressed, that's one of those anchors that helps to bring you back into reality. But if they call you something that you're not used to, that's not really what happens. And so that's the first thing, right? And as you're aware, a lot of times we hear things where people really want to be addressed formally. I know it sounds formal, but I want to be called Mr. Jones. I want them to call me that. Okay, Mr. Jones, whatever you want, that's fine. And so that's that first one. And then the second question about what brings you joy. It's amazing, again, the breadth of the answers that people give me when they're answering that. And then what does the team need to know about you? They're all over the place. I'll give you 2 stories from that, recent stories. So I did an interview with a guy who was 52 years old, and he's going to need a liver transplant, but right now his MELD score hasn't gotten him into the place where he needs it. And it's idiopathic. So it wasn't alcohol or anything else that got him into this thing. And he said to me, you know what the team needs to know about me? I'm 52 years old. I have a wife. I'm so blessed, a wife and 3 children, all of whom love me. And this journey to this transplant is so lonely. Waiting to find out if and when I am going to get a liver, I feel absolutely alone. And that was so important to hear him say that, and I'm not sure that all of us ever really considered that aspect of what's it like waiting for a liver, waiting for your MELD score to get you into a place where you get to get one, maybe, if a suitable donor is found. And then another patient I had recently was a guy who had just had an MI, also a young guy. And I went in to talk to him and he said, well, you know what I think the team needs to know about me? I don't really believe I had a heart attack. And, it's really going to be hard to change my life and to take all those medicines and do all that stuff they want me to do, because I don't really think I had one. I was floored. I mean, I think you probably want to know that, right? About this patient if you're trying to get him into rehab. And then,
Sure.
and then the question about peace, of course, that also is all over the place. And I'll give you one more story. And you can imagine I have endless stories, because for me, this is the compelling thing about it. So I recently had a really young guy, so barely out of pediatrics, on one of the medicine units on the adult side. And he had a syndrome that affects only about 1 in a million people. And it wasn't looking good for him. And I saw him the first time and he was just charming. He was really tall, this huge wide smile. He was very lovely. We did a TIMS file. And then 2 weeks later, I saw that he was back in the hospital. And I was so upset about the fact that he was back in there. So I went into his room and I said to him, so what are you doing back in here? I thought we agreed we would never see each other again. And he said, yeah, and so it turned out that in his file, one of the things that brought him joy was video games. And I said, I can't help you with the video games. And he said, well, at this point, even an Xbox would help. And as it turns out, in the Children's Center, we have all kinds of Xboxes. And so I called and I got an Xbox brought to this guy's room so that he could at least have that while he was in the midst of this whole thing, the second hospitalization.
Wow.
So it really runs the gamut.
Well, I'll make 2 observations. I'll ask one more question, and then I'm already seeing some things in the chat. So I want to be sure that people on the call get to ask their questions. But the 2 observations are first that I think we, as clinicians, often, I think training almost beats it out of us. We impoverish the experience we have with patients by reducing the things they tell us and they are to data points that we think somehow are what we're supposed to be paying attention to. So in classic medical training, and I probably I think it was Philip Tumulty, a legendary Hopkins professor, wrote the history and physical book that I used in medical school. And it talked about recording the patient's chief complaint in his or her own words. And I can't tell you how many times that I saw over the course of my career working with students and residents and other doctors, a patient would come in talking about chest discomfort that feels really weird, and the doctor would say, well, the chief complaint is chest pain. How long have you had your chest pain? And the way that we would substitute what we thought was medically significant for what the patients would tell us. And my favorite chief complaint ever, I trained at Bellevue, and one of my colleagues had the same belief I did, that you really were supposed to use the patient's own words. The answer to the question, why did you come in today, or what can I do for you? The answer was, the morning people, found me in an elevator and brought me to the greatest hospital in the world. Oh. And, it's like, well, that's his chief complaint. Like, that tells you a lot of things about him, but we really kind of screen that stuff out. So that's one observation. And the second observation with respect to your method, and there'll be a little bit of a question here too, I guess. So when you awaken people, as you do by having them listen to a TIMS file, that wait, there are 4 other questions I could be asking. I could be asking what brings you peace. I could be asking what brings you joy. Do you see any signs, and I'm not asking you to tell me for publication purposes, but anecdotal evidence would be fine, that the very experience of doing this is broadening the universe of things. The very experience of hearing a TIMS file is changing the way clinicians talk to their patients by being able to pay attention to things that they used to be ignoring.
There's no question that that's true. And so this MICU study that I referenced, and then this one that we're just going to get ready for publication, absolutely demonstrate that it totally opens up clinicians to, it improves 2 things: compassion, self-reported compassion and empathy for the patient, and also improves their communication with the patient and with the loved ones of the patient. And they all say that. Now, in full disclosure, I would also say that in the study in the MICU, we did see a signal for harm, where some clinicians reported that listening to these files was heart-wrenching, and that they felt like, this might be really hard for me to listen to these on a regular basis. And we want to explore that further. We're about to start another study that's going to be in the MICU also, because that's a high acuity and high mortality unit. So there's a lot of that kind of happening that doesn't happen to the same degree elsewhere in the hospital. So we'll be back exploring that a little bit further to see what exactly is it that's causing distress versus improving communication and increasing empathy.
Right. Well, if the pathway to avoiding distress is to shut down empathy and have no ability to recognize the patient as a human, then maybe you're in the wrong line of work. And you know, it's definitely hard, and it's definitely painful, and it's definitely scary, but it is sort of what we do, who we do, why we do it. I'm going to ask one more question, and then I really do want to turn it over to the chat. So this is something that you've now got a technology, and you told me in the pre-interview something that people don't know, which is you are working with a tech team at Hopkins to take longer interviews that are responsive to those 4 questions, and using natural language processing and artificial intelligence and wizards and magic and whatever, turn that into a 2-minute file automatically without having the skilled communications person cut down an MP3 file. So now you have this scalable thing that anybody with an iPhone could have an app that could ask these 4 questions, could create an MP3 file of whatever length that will be distilled to a 2-minute file that could be loaded into Epic and could be played on rounds. I mean, you might as well be the BRCA1, BRCA2 patent holder of, now you've got a new diagnostic test, you've got a new clinical intervention. Nobody else has it. And it is magnificently scalable, and it could really be transformative of the way we do clinical care. What's the scale and spread strategy? How are you thinking about that?
So the app that you're referencing is under development at Johns Hopkins, and right now they're working on it just for the iOS platform. So it's not even going to be for Android-based phones out of the gate. We hope to have the prototype app in use by the end of the year, so that we can start getting lots of people to use it. And then simultaneously, we're working on how we can implement this into Epic and have it be a part of the durable medical record. The reason it should be is because, let me reference again this liver patient. This man is going to have multiple encounters with the healthcare system as his hospitalizations increase. And then when he hopefully comes in for a transplant, or wouldn't it be wonderful, he never needs one, right? But he will have multiple encounters. And to ask him to continue to record one of these things every time he comes in, that's just ridiculous. And so we're also working to simultaneously get it fully integrated into the durable medical record, along with a photograph of the patient, either their best photograph or doing something they really love or whatever, because we found that those things are also really helpful. So that's the hope and the intention. This app has been under development for several months, and there is an institutional commitment to getting it fully implemented. Once it's implemented and we validated it, and as you know, we have to do our obligatory study on it, it will be available. The intention is to have it available in Epic's App Orchard, so anybody will be able to use it anywhere. And we would also like to see it not just in the inpatient side, but also on the outpatient side. One of the studies that we're going to start accruing really soon is going to follow this as a patient. These are head and neck cancer patients, pre-procedure, once they have their procedure, their hospitalization, and follow their outpatient care and see how it's implemented there too. So also in my chart, And we are formally studying the patient's experience, their own experience of recording the file and how that changes the dynamic with their clinicians, the full breadth of clinicians. So I'm going to guess, I say that there's like glaciers and then there's Johns Hopkins. And so I would say that I'm hoping by the middle of next year, we're going to have something that's really practical that everybody can use. And clearly that's the intention.
Again, Elizabeth, I may be idiosyncratic in my view of what a major contribution to patient care looks like, but I think this is a major contribution to healthcare. I feel like if more people knew what you were doing, people would be beating a mousetrap to your door, and they would really, there would be a lot of interest in this. So I think prepare yourself for that, because I just think it's an extraordinary solution to what's been a very refractory problem. And when people think about electronic health records, and a lot of the press in electronic health records is the clinician burnout and the inbox and the basket, and this is terrible and it's awful. And I think we can often miss the ways that we can use technology to humanize care, to improve care. And I think you found this extraordinary way to use technology to humanize care in a way that really could have a major impact on the care that patients all over the country get. So I want to turn it to Jamie to help me manage the chat. If there are questions in there, I'd love for you to put them out there for us.
Thanks.
Do you mind just 1 second if I want to say, Richard, first of all, thank you so much for the kindness and for the magnanimity of your comments, which are really, really meaningful to me. And I have said and shared with you before that for me, the other really critical part of this is that I have seen how transformative it is for clinicians. And I love clinicians. I love patients and I love clinicians. And I see so many clinicians who are transformed by their ability to resonate not just with the humanity of the patient, but with their own humanity. These are stories that, you get to hear about, oh, I have a grandmother, Ethel, or I've got a Shih Tzu, or I like Chinese food. Those are all things that let us join each other. And this is a whole enterprise of shared humanity. And that's what I'm really passionate about, because if we don't have all the clinicians in the healthcare world, we're not going to have any healthcare.
Right. And clearly, one of the drivers of burnout is impossible workloads, and one of the drivers of but I think one of the biggest drivers is absence of meaning in work. And it's really hard to project meaning into the care of a prone ventilated patient who you know nothing about. And the idea that you can start constructing the life that you're working on, trying to preserve, save, and restore. That's a beautiful thing. And I think it really will help a lot with providers. So Jamie.
Yes, well, it's been great to learn about you, Elizabeth, and hear more about the TIMS program. If anyone in the audience has a question, please feel free to raise your hand. But there are some questions already in the chat, and I did get one private message. Elizabeth, would you mind quickly just repeating the 4 questions that you're asking patients?
Certainly, I can start with that. So the first question is, how do you want to be addressed? And the second question is, what brings you joy? The third one is, what does the medical team need to know about you to care for you best? And the fourth question is, what brings you peace?
Thank you.
You're welcome.
Then Lindsay asked if you could share more about how your background in communications made you the right person to lead TIMS.
There's no question that the daily radio spot of having to create something that's a minute long and that conveys a message in a minute in language that is hopefully accessible, but not simplistic, and that still retains truth, has been a really important skill to be able to bring to this. And so I say all the time, you know, Hopkins has tolerated me for 22 years, and maybe this is the payback that they've allowed me to continue in the role of reporting on medicine and develop the skill that enables me to really truncate material so that it's in chunks that people can really use. So yeah, there's no question that the two skill sets need to work together.
And then Harv asked, how are you initially contacted?
So on the MICU, it was all comers. So during COVID, when we were full bio, all comers, all patients were eligible. Anybody who was non-communicative, because also during COVID, we expanded it throughout the Johns Hopkins Hospital and Johns Hopkins Bayview Medical Center, which is another hospital that's part of our group. And anybody who had communications issues was eligible. So let me just add that we're really blessed in that we have hugely robust translation services. So a TIMS file could be created irrespective of what your native language is. And we were able to, even when we didn't have an in-person translator, get one in on an iPad and be able to translate. If anyone, whatever language it was that's your native speaker, we could do that. And then we could have the TIMS file be accessible by having that same translator translate it into English and then run it underneath. So it's a very equalizing kind of a thing to be able to employ. So all comers initially, and then on these all the other units that I've been on, I usually go onto the unit. I ask the charge nurse who they think is suitable for a TIMS file, and they tell me. And so that would be somebody obviously who can communicate, who has agency, who isn't otherwise struggling with things that they might be struggling, like with intractable pain or whatever, immediately post-op. So all of those patients, and then I would just go and do all of the patients who are on the unit. Ultimately, it would be nice to be able to get people who are able to communicate to record one at the initiation of their hospitalization. That's the ultimate objective.
And we have quite a few comments from Chris, who said that they're going to share the talk today, which it's already recorded, and we'll have it online within the next few days, and we'll email it to everyone on this call. But he'll share it with what matters to you, because he thinks recordings would be a great part of their work that they're doing. And Thelma asked or said, I recently transitioned to the HIE side of health care. I'm wondering how I can start these conversations in a space that seems to focus more on revenue and where most partners are for profit.
Boy, that's really a good question, isn't it? I think that even in a for-profit environment, I still think that there's a place for a person's objectives as the patient. And so I'm not sure, Richard, you want to step into that space?
Yeah, actually, I'd be happy to take a whack at that. I think there are a couple of arguments you could make, cases you could make, value cases you could make. One of them I do believe relates to the burnout argument, that I think that people, and it sounds like Elizabeth has published some stuff that may support you on this argument, that clinicians are more satisfied, feel better at work. And burnout's really expensive. That turnover is expensive, replacing people is expensive, and these days finding people in healthcare is expensive. So if there are things in Elizabeth's studies that suggest that that people feel better about their work, clinicians feel better about their work, for many healthcare organizations today, that's a primary value. Another thing, it is the sort of standard market share argument that patients who feel recognized and as patients are more likely to use your healthcare system, and patients who aren't. And honestly, I mean, I'm no longer in the direct delivery of healthcare, but if I were East Side Community Hospital in an American city, I would want to put this in before West Side did. And if I were West Side, after East Side had it, I'd feel like if I didn't get this soon, I was going to lose market share, because I really do think it is a patient satisfier to be recognized. So I think two arguments that people would resonate with, and again, Elizabeth's giving you some evidence for those to be evidence-based arguments, not just hunches, that staff satisfaction goes up and patient satisfaction goes up, and both of those things are things that people who run even revenue-focused for-profit organizations care about.
And I have a few more questions that were sent to me privately. Sarah asked if you could elaborate on how the 4 Tim's questions were narrowed down and how you developed those 4 specific questions.
Surely. So we reviewed the audio files from the MICU, which were the open-ended interviews that we did with all of the loved ones of people who were non-communicative. And then also when we transitioned to asking patients themselves, and we just were able to discern from those reviews that those were the 4 questions that really resulted in the greatest yield with regard to answers that were meaningful to patients and also highly personal. And that's how we got there. I think now it's a really good question, because I think now one of the things that I would be very tempted to ask, but I'm not sure I would get a lot of really straight responses, would be, tell me something about you that no one knows. I love that. And it takes a lot of bravery, of course, for somebody to step into that space and answer that question. I'm not sure they'd want that to be a part of their continuing medical record, but it's a question that I really like. But those are ones that we determined we're going to have the greatest yield.
Thanks, Elizabeth.
Surely.
And another question I received privately, do you think that Tim's would have been successful if it wasn't created during the pandemic?
I think the pandemic, and I bet everybody on this call would ratify the idea that we've only begun to learn the lessons that we're learning from the pandemic. And I think that it definitely created a space to be able to have Tim's come up. And I'm not sure that it would have come up with the rapidity that it did if it had not been the pandemic conditions. And then I would also reveal something about my fine institution, which is that it would be really tough now that I'm having multiple struggles with the IRB to get a lot of these initiatives. There were a lot of barriers that were down during COVID because people wanted to be able to really look for solutions and implement them and see if they helped. And so I think that we benefited from that a lot from the pandemic. And so having said that, I would say that I think we also know now that this is a really effective thing to do, and that the audio file format is extremely practical. It's a small file. It's easy to update. Somebody's voice and the language that they use to describe who they are also extremely revelatory. So I think that we know now that it's really helpful.
And the last question I'm seeing is, how can a small or less resource system imitate Tim's?
And I would say that as soon as this app is available, you're going to hopefully know about it. We're going to let everybody know, and that utilization of the app can be done by anybody. It doesn't have to be a chaplain who asks these questions. The app will be able to be utilized by anybody in the healthcare environment to create this file.
And Sarah has a follow-up to her initial question. She said, to Chris's experience of asking, what are you afraid of? She's wondering if you've thought of asking something in the future related to the question, and specifically fear of discrimination.
That's such what are you afraid of? Yeah, I don't know. When I savor that question and I think about myself asking it in a clinical environment, I think it might really change the nature of the interaction a lot, and maybe not have patients be that forthcoming. So that's another thing about those 4 questions, is they don't put someone back on their heels, and they don't raise issues that are frightening. And you're well aware that in the healthcare environment, when you're an inpatient, it can be a pretty scary spot. And I think I would want to avoid that.
Yeah, it certainly. I saw the comment in the chat, and I could imagine in the context of a relationship already existing where there was some level of trust, a clinician inquiring about that, with the implicit promise that I'm asking you this so that I assure that won't happen. But certainly, if you tried to scale this up and just put that question out there as question number 5, I'm with you, Elizabeth. I think it would wait. Why are they asking me that? What are they going to do with that? And is this going to be a Winston Smith 1984? Now they know it's rats. I'm in trouble. It's a lot of vulnerability there. So it's challenging. So Jamie, any more in chat? And if not, I'll make
No, I'm not seeing anything
No.
else.
So I really, Elizabeth, I just can't commend you enough for your creativity, your, in life, I think our collective challenge is how do we use the skills and experience we have to make the world better? How can we be synthetic? How can we draw on things that we have experienced or that we know and put them in service in some other place and combine them in some way? And I think great ideas really do come from kind of interdisciplinary approaches to challenges and problems, and your ability to cross the boundaries between being in communications, being a chaplain, then it's not just a chaplain, but it's clinical pastoral education. It's a chaplain at the bedside, at an especially vulnerable, especially both for the patients and frankly for the team that's taking care of them, as you have realized. And for you to put all that together into first a Nobody Dies Alone program, and then this, I just am in awe of your energy, your creativity. We didn't ask you, and always when you talk to somebody about their success stories, I guess it's a great question to ask, what were the barriers you had to overcome to get where you are? But with 6 minutes left, we're not going to hear that, and we're not going to end on that. We'll know that there are some, but we'll also know that you got over them because you are where you are. And I think you will. I think you will be really. I think this is going to be something that you heard it first, people on this call, and I heard it first in preparing for this call, and I really look forward to it being something that. And I love what somebody put in the chat. This will build trust between patients and doctors. It absolutely will. That's the theme of these calls. You are truly an exemplary person, program, idea. Thanks for sharing it with all of us.
You're so very kind. And I'm going to get this recording just so that when I'm feeling really frustrated, especially with the IRB and with trying to get changes to Epic, which anybody who's had that experience knows very well, I'm going to listen to it and make myself feel like, oh, it's not quite as terrible as I thought. So thank you very much for the opportunity. I really do appreciate it.